So now go on with something which is a little different in the sense that when I was a resident, using fixators for pelvic fractures was not really something that was accepted, in the sense they had developed all these fancy C-clamps and things like that. But Pradip does, being in KEM, a lot of pelvic surgery, and he has experience with using these external fixators for the treatment, at least the early treatment of pelvic fractures. So Pradip will share his experience and knowledge with us.
Thank you, sir. Good morning, all. So that's the place where I work. So external fixator in pelvis can be used either a temporary measure or a definitive measure. Temporary, of course, when the patient is he has hemodynamic instability, then we want to stabilize the blood clot and reduce the pelvic volume. So in these cases, we want easy and fast application of the external fixator. Whereas sometimes definitive fixation, when internal fixation for reason cannot be done, because of wound, suprapubic catheter maybe, or sometimes as a definitive device, suppose there is a lot of comminution and then doing a very morbid internal fixation procedure, the risks are much more than putting a simple external fixator. So such situation also a definitive fixation can be used. And in such situation, we want a fixator which has a very good stability. So pelvic external fixator can be broadly classified into the anterior and posterior. The anterior one are the they are basically classified based on where you get the anchorage point. So anterior anchorage points can be in iliac crest, they can be into supraacetabular area, or they can be in a subcrestal area. Posterior anchorage point can be the Gans clamp, which was used in the past, or sometimes rarely we can do the posterior external fixator, where we get anchorage into posterior part of the iliac crest. So broadly, however, these two varieties are the most common kind of external fixator that are used. The conventional, by conventional I mean the iliac crest kind of a fixator and the supraacetabular kind of fixator. So we're going to discuss these two fixator based under different headings, such as the technical details, the surgical anatomy, the biomechanics, and post-op. If you see the pelvis and if you see the bone densities of the pelvis, we can see that the area that is above the acetabulum, that is the area generally superior to acetabulum, that half is generally used for external fixator. So majority of the bone density is into the posterior part, then along the iliac crest, iliac tuberosity part of the iliac crest, and then in the supraacetabular area. And these are the areas generally used for anchorage points. So if you cut the pelvis vertically along the iliac crest, along the iliac tuberosity, if you see, we can see that thin line, the inner and outer table, and in between that is the cancellous bone. So generally all other diaphyseal part which we talk about the cortical fixation, here is the area where we put the pins intracortical, because we want a large length of the pin to be passed. So if you see the anatomy, the average thickness in, of course, Western population is around 12 mm, and the cortices occupy around 20% of that thickness, and the length of pin insertion that can be safely go in between the intercortical location can be around 40 millimeter in diameter in length. And if you see the profile view of the ileum, again there is a gross variation in this view. We can that S-shape profile, S-shape of the ileum can be different in different people, and sometimes you can have a single C-shape curve as well. So again, that is different variety of pelvises can be available, and then you need to see it before you do the external fixator. Again, if you see the sagittal cross section of the iliac blade, again we see gross variety. Sometimes it can be a very thin blade, sometimes we get a good part of the iliac cancellous bone in between the two table. Again, this needs to be seen previously before you are contemplating a supra iliac crest kind of a external fixator. For the supraacetabular fixator, if you take oblique cross section of the pelvis and see it from the top, that is in the left diagram, you can see that there is a nice corridor from the AIIS to the PSIS. So there is a nice corridor between AIIS to PSIS, and that can be utilized for passing external fixator pin. So that's how it looks on the CT. At different level, we have different shapes of this corridor, and we can definitely pass a very long length of a pin that can start from AIIS till the PSIS. So that direction is around 20 degree medially with respect to the vertical line. And if you see the sagittal cross section, we see a nice triangular area, and that is full of cancellous bone. And again, this is a very good area to pass a external fixator pin. So that's how it looks on the cross section. So if you see the hip capsule, that hip capsule takes origin around 15 to 18 millimeters superior to the acetabulum, and then our external fixator pin has to be above that, just to avoid the intra-articular penetration of the external fixator pin. If you see the technical aspects for the iliac crest fixator, there are two methods, the open and the percutaneous. I am just talking about the percutaneous method here. You can take two stab incisions that are perpendicular to the iliac crest line. Why perpendicular? Because once you put the pin, to reduce it, you are going to bring those pins together, and then the skin incision can get stretched. So that's why you need to have a incision that is perpendicular to iliac crest line. So you can extend that incision. You can extend that incision along the line, and then you can get the skin tenting will not occur. So you can pass two K-wires along the inner and outer tables of the iliac crest, and in between two you will have the corridor, and through that you can pass the pin. You can just insert a pin, and that is around the inner 1/3 and outer 2/3 of the iliac tuberosity, and make a small drill hole there, and through that you can just pass the pin around 20 to 25 degree medially, and 10 to 15 degree quadrant when the patient is in supine position, and just to make a small drill hole, and then the pin will find its own track on that. Around 40 to 50 mm threaded pin can be passed. And you can pass a second or third pin accordingly where you have passed the first pin. It can be anterior or posterior to that, and you can have a good coverage of the iliac crest. And you need to see this view. This is the obturator view in which we project the beam that is from the side 45 degree from outwards and focuses on the hip. So you see the obturator foramen in profile view, and in that view we can see that the cross section of the ilium will be seen like that, and the pin is to go in between these two cross sections. And you want to avoid the articular penetration, the cortical penetration like this, because once this happens, the strength of the pin decreases. So that we don't want that. We want picture like this. For the supraacetabular pin fixation, again the patient is in supine position, and this is entirely radiologically dependent procedure as opposed to the iliac crest pin where the radiology is minimum. Only at the final stages you need to take radiology, whereas supraacetabular fixator right from the beginning you need to take radiology. So the start point is around 4 centimeter below the AIS, and around 2 to 3 centimeter medial to that. So that is the line that is the point where we start we take the incision. And from that incision we aim into the area that is just above the acetabulum, and the view that you need to take is this. So you need to take a obturator outlet view. So by meaning obturator view, you need to focus from medial to lateral to medial direction 45 degree, and from outlet I mean it is from caudate to kephalate direction. So in that direction this supraacetabular area get completely isolated from the joint, and what we see is a triangular nice shadow of the pelvis like this, and you can identify a triangular shadow like this, and it resembles a tipi of the which we use in camping. So that's why this view is also called as a TP view, where we try to see this TP kind of a picture, and at the center of that TP we need to mark our entry point. And I generally use a owl as a starting as an instrument to start, because the drill tends to slip on either side, so I use a owl. So with that owl I make a small hole there. So so you need to take a entry point like that. The pin direction is around 20 to 30 degree medially, and 20 to 20 degree cranially, and you direct it just above the sciatic notch. So that's why you need to take the next view, that is the iliac view. So this is the iliac view. In iliac view I mean 45 degree or from medial to lateral direction, where you see the sciatic notch like that, and you see the entire ilium blade in profile, and our pin needs to go above the iliac, above the sciatic notch. So that's the view that we get, and our pin needs to go like that. So we need to see that our owl is going into that trajectory, and it is not going towards the sciatic notch. The third view which we want to get is something called as the rollover view. So this is again an obturator inlet view. Obturator, by obturator I means it is lateral to medial direction, and inlet I mean a cephalochordal direction. So in that you can see this entire ileum in profile, like along the axis, and you can get this view. So you can get one view from AIIS to PSIS. So this corridor we can see in this view, and we need to see that our pin is going in that corridor in between the two cortices. So that's the direction of our pin, and it needs to go in between these two cortices, and we can go as posteriorly as the PSIS. And we can pass a second pin that is little bit superior and lateral to the first pin, and it should be parallel to the first pin. So that's why you can pass a second pin, and again you can check that your pin is going in between the two cortices as posteriorly as possible. Then you can connect these two pins by various configurations. So I use Esculap rod again, and this is for the reason that I can bend these Esculap rods. It's very difficult to bend the AO rods, and that's why I prefer the Esculap fixators for a pelvic thing, because I can bend it and I can use it, place the rod at any point where I want. And that is because I want to give space for the further procedures for the urologist or sometimes the GI surgeons. So this is one case where it presented late. Again, he had a suprapubic catheter in situ, and we can see that we cannot do suprapubic catheter in situ. We cannot do internal fixation because it will tend to give rise to infection. So it was again reduced posteriorly to whatever possible, and posterior fixation was done by the SI screw. And we can see that we have passed the orthogonal fixator, in which we have passed the supraacetabular as well as the iliac crest pin, and then you connected this with two rods, and then they were connected again in turn by three different rods. I'm sorry. Mute. Okay. So, and that is after fixator removal. So when do we remove the fixator? When the patient is able to walk without pain, you need to loosen the fixator pin. And again, if he is not getting pain, then at that point, I think is the right time when you remove the fixator, and that is at the end of the fixator removal. Another case, a 40-year-old lady with a vertical shear fracture with again the urological injury, and she was again fixed by the orthogonal kind of fixator, two supraacetabular pin and one iliac crest pin, and that was fixed. And mute. Can you mute it? Yeah. So yeah, it's not happening. Just pull out the let it be. Okay. So another kind of a injury now in this patient has a stoma, a urological injury, and vertical shear injury, and he needed to have a lot of procedures that needs to be done on the anterior aspect of the acetabulum. So we have to use a stent home kind of a fixator, wherein he can the other surgeon can do their procedure, and again he can walk. Another kind of indication where he had a wound, laparotomy done, and he has a big moral level lesion, and if you see. Okay, I'm just skipping through that because of noise. The entire pus used to come out, and of course we cannot do the internal fixation in such situation. So looking at the biomechanics of the fixator, we need to see the pull-out strength of the pin, the bone-pin interface, what happens at that, the stiffness of construction, what is the possibility of modification. So the strength of the pin again, the pin-bone interference is one of the most important thing in pelvis fixator, and conventional intercortical method has a larger pull-out strength than in transcortical in the thin crest. That's what we have already seen. And in case of supraacetabular fixator, a comparison of the iliac crest and a supraacetabular fixator was done in B1 and type in B1 that is the open pelvis, and C is the vertical shear pelvis. So we can see that the the supraacetabular, the anteroinferior means the supraacetabular fixator. The supraacetabular fixator has a great strength in the open book kind of injury. However, this problem is still not solved for the vertical shear kind of force. None of the fixator, they give good stability. So all kind of fixator, they have equal with respect to the superior migration. So that problem is still not solved. Again, for SI displacement, the supraacetabular fixator again has given good strength in all kind of a thing, except the cephalochordite, again it is almost the same. Biomechanical comparison of different frame design was done, and it has been found that the two straight rod, that was one of the most the strong fixation of the pelvis amongst all these frames. Again, orthogonal fixator versus the supraacetabular or iliac crest fixator was compared. It was seen that when there is an in-plane loading, that is, the open book and closed book injury, the orthogonal fixator is much more better. But when these are out of plane, that is the vertical shear, they do not do better than the supraacetabular kind of fixator. And again, there are again different fixator frame were studied, and again, that was the thing is that it is insufficient to provide full stability in vertically unstable pelvis fracture. For the pin diameter, it follows the same thing. Larger the pin diameter is better is the stability. However, very large pin diameter can cause the fractures, microfracture at the pelvic orifices, and then lead to pin loosening. So the thing that was suggested that you use the pin, the unthreaded portion can be large, and the threaded portion can be in smaller diameter. That was the suggestion, where the pins are not available. Again, addition of this symphyseal pin increases the stiffness to a large extent. One of the most important thing now is this modification, where there is a pre-tensioned external fixator, because if you see all these fixator, they work on the basis of hinge. So when you put the fixator, you put the hinge and that will close. But what happens that when you close it, it tends to open sometimes posteriorly. So they applied a circular rod like that. So the rod was applied and it was pre-tension. So when the tension was released, the rod used to close and it used to give the posterior compression. So that modification is only possible with the supraacetabular kind of fixator. That is not possible with the standard iliac crest kind of fixator. So complication wise, the lateral cutaneous of the thigh injury is more common in supraacetabular kind of a fixator. Pin tract infection, again, is more in supraacetabular because larger soft tissue tract. So the crystal, it is a smaller soft tissue tract. And impingement on trunk while sitting. So when you try to sit, the supraacetabular fixator tend to impinge onto the lateral aspect of the abdomen. That are the problems with supraacetabular fixator. However, the stability is more with supraacetabular. So in take-home message is that conventional fixator is easy to apply, is suitable for emergency and temporary use. Supraacetabular fixator is more strong. However, it is fluoroscopy dependent, and it is useful as a definitive method. And I think combination is much more stronger fixation than using both this fixator in isolation. Thank you.
Thank you, Pradip. So, as a general sort of, in all the patients that you treat, what is your use of fixators? Out of 100 patients with an unstable pelvis, how many do you use fixators?
It depends, because we get generally patients that are already stabilized. By the time patient reaches to the center part of the city, the patient is either succumb to the injury.
Either stops at Sion?
Yeah, either succumb to the injury or it is stable. So those patients, I have, frankly speaking, I have done only one emergency external fixator in my life. And I must have done around 20 definitive fixator in my life. And the total number of fixator is hardly, I think say 20% of this thing. So majority of they are amenable for internal fixation. So when your internal fixation,
so by the time they've come to you, they're already stable. They don't need so much of emergency treatment.
But many times the internal fixation cannot be possible. So those patients are in my hand the indications for surgery for external fixator, where there is moral level lesion, there is suprapubic catheter, there is stoma, and we don't want to do plating in that.
Right.
So these are
the from point of view of hemodynamic stabilization, what I have, my understanding is that wrapping them in a sling is as good as a fixator. Is that correct?
Yes. So just take a sheet, cross it and put two hemostats there, and that reduces the, basically there is big controversy whether reduction of the pelvis volume leads to the stabilization or whether it's the stabilization of the clot, because the pelvis volume doesn't really decreases very much by closing it, because anyway it is, it continues with the abdomen and all. But just because they are the bones are compressed, that stabilizes the clot and that stops the bleeding. However, if there is a major bleeder inside, again,
then either of them is not going to help.
Yeah.
So the sort of bottom line that I can take from what you are saying is that the fixator is really kind of not emergency, not definitive, but provisional. When you've got a lot of stuff that needs to be taken care of on the abdomen, then you use it. Yeah. Dr. Chandak, you also do a lot of stuff. Dr. Modi will answer, then we'll.
What is your experience of packing the pelvis, which is supposed to be done before you do the external fixation? Do you get, what would be the percentage of cases that require packing of the pelvis to prevent hemodynamically stabilize the patient, or you don't get such patients?
Yeah.
And if you do not get, what is the experience of your colleagues at, say, Sion Hospital, which get the larger number?
So,
or what is the world literature review which indicates such a situation?
Yeah, so I'm again going to talk on the surrogate knowledge, because as I said, I have not yet encountered a very unstable pelvic patient which I can salvage. So now, based on what discussion occurs in this, the open pelvic packing is one of the very good method of achieving hemostasis. It needs to be done by a standard laparotomy approach because it is really fast. You need to use lot of sponges, you need to pack it, and you need to keep it like that for at least 24 to 48 hours, and after that you need to take those mops out for you to have this pressure effect and causing the hemostasis. It again can be done first, of course, whenever as the acute management of the pelvic fracture goes, you need to assess whether the patient is stable and the fracture is stable. If the patient is stable, fracture is stable, that goes for the elective management. If the patient is stable and the fracture is unstable, again, since the patient is stable, we can do it as a management in an elective setting. If the patient is unstable and fracture is unstable, I think that is the best indication for stabilizing the pelvis, assuming that this instability is because of the pelvis. And then we are going to reassess whether the patient has stabilized after that. However, if the patient is unstable and the fracture somehow looks stable, or even after fixator, your patient is still, the stability is not getting achieved, hemodynamic stability, I think these two indication would be the indications where you would like to explore the patient and try to see. Areas where the rapid angiography can be possible, it can be done, angiography can be done to see a bleeder, and of course Western literature talks about the embolization of these bleeders.
Typically, we use it in a patient where a patient is brought in emergency. We give a volume challenge. His BP initially rises and then again falls down.
Yeah.
That is the best indication where we have a rapid external fixator, and that stabilizes like anything.
Yeah.
And of course, if we can get angiography, and we had a chance to do angiography, and on table they were able to block the bleeder inside, and the patient stabilized very nicely.
I wanted to know whether any use of GANS C-clamp is possible. We are not able to, it's not available here.
Yeah, so GANS clamp was originally decided because originally described for the posterior instability, because if you see all these kind of fixator, they are generally anterior kind of this thing, and there was a lot of literature which correlated the posterior injury to the instability and all these things. So they used to put these two pins there, and a clamp was used. The problem with that, a clamp is really heavy. The pin used to perforate into the cortex. So that was the time where the use of
it's not available.
Not available,
and
not
I don't think
use
anyone
also.
has. You have anyone has experience on it? Nobody. Last question.
All those angles which you have described for placing the pins are in an intact pelvis. In an injured pelvis, all those angles will be haywire.
So
you depend on a feel after you are using cannulated pins.
No, some simple pins.
Okay. So you're depending entirely on the CM or your feel when you put a K-wire across, say for example a supraacetabular pin, where you want to put that long pin and all those 15 degrees angle, medially, inclination, all are described for an intact pelvis. So how do you address that issue?
Yeah. So if you see the pelvic fracture, this thing, which is the thing which breaks the pelvis is the lateral compression injury type. And if you see the trajectory of the pelvic fixator pin is the same as the LC2 screw, the lateral compression 2 screws. So this this pin will be an internal fixation device as well as an anchor device for those LC compression type. Rest all other fracture types, if you see, the pelvis is relatively intact when you are talking about pelvis, not acetabulum, because in acetabulum, supraacetabular area will be violated. In pelvis, mainly the PSIS, this crescent fracture area that is violated, and still it is way posteriorly. We can still get around 60 to 70 mm length of the fixator if you don't want to traverse that fracture.
So there's a lot of use of X-rays and radiology.
Yeah.
Thank you, Pradip. Yeah, Milind.
In some slightly neglected presentations, we can just modify, add Elizarov components, and we have succeeded in doing secondary reductions
Yes,
in neglected presentations.
yeah, so we had one case, and at that time I was working with Dr. Bhosle. Of course, he was with Elizarov. So we could salvage one case which was very badly displaced pelvis, and Elizarov ring were applied and rod used to use to compress, and it was salvaged.
Thank you. But then we'll keep going ahead. We'll discuss this in coffee time.